Good afternoon. My name is Karthik RajaseKARAN. I'm one of the head and neck surgeons at the University of Pennsylvania in Philadelphia, USA. I wanted to thank my good friend Illyrio for the invitation. Today I'll be talking about oropharyngeal cancer in the HPV positive era. I have just a couple of disclosures, none of which affect my talk. So I'm just going to start off with a little case presentation. A 52-year-old man noted a neck mass while shaving. On exam, he had an enlarged right tonsil, also had two ipsilateral nodes, largest is 3 centimeters. The needle biopsy came back as a squamous cell carcinoma, P16 positive. This was staged as a stage 1, clinical T1 /2 N1 MX. That's what it looked like on exam. And these are things we think about. What are the options for our patient? How do we counsel them? What outcomes should we address? And what clinical trials are available? And so my objectives are really to discuss the evolving treatment paradigm for oropharyngeal cancer, review surgical approaches of transrobotic surgery, and touch upon some clinical trials. So historically, for the treatment of these tumors, radiation was how these tumors were treated back in the 1920s. Then, with the advent of ICUs and antibiotics, we started to do big open procedures in the mid 1900s. Then, with chemotherapy and cisplatin, the pendulum again swung towards chemotherapy. And then in the early 2000s, we found the HPV-related head and neck cancer. And we found that this tumor biology was very different than the others that we treat. And then again in 2003, translaser surgery was discovered. And then 2005, we started transoral robotic surgery at the University of Pennsylvania. And then we found that the HPV cancers in 2010 actually have a survival benefit. And now we have the IMRT and single port Da Vinci robot. So why is this relevant? Well, HPV oropharyngeal cancer is on the rise. It is projected to be the third most common cancer and it will actually surpass cervical cancer. So the AJCC staging for these cancers also been updated. It's been updated based on the fact that the HPV tumors just tend to do way better than HPV negative tumors. You can see right here, the T4 staging has changed, and we went from N2A, 2B, 2C to clinical staging and pathologic staging, where the pathologic staging has been combined to just N1 or N2. So what are some pre-treatment considerations? So certain things about the anatomy. We all know this. This is the tonsil, the palate. This is where the base of tongue is. You can see there's a rich blood supply. These are the muscles that we come across as we do the surgery. Then in terms of the neck nodes, you can see level 1B is not as common, but level 2 through 4 are the most common locations where these tumors tend to metastasize to, and this is why we treat these levels of the neck as well. So what are some considerations? Well, anytime we think about a patient who is a candidate for robotic surgery, we think about three things: patient factors, disease factors, and treatment factors. In terms of patient factors, we think about comorbidities, the anatomy, so whether they have trismus or kyphosis. We think about patient priorities and access to care. Disease factors are the tumor extent, nodal burden, whether they're HPV positive versus HPV negative. And other treatment considerations are morbidity, functional outcomes, prior treatment, surgeon experience, product availability, and perhaps and availability of radiation. So surgical approaches. I'm really only going to be touching about transoral robotic surgery as far as the endoscopic approach. So as we know, we started off with the Da Vinci robot. Then we're now at we first actually had the S, then the SI, now XI, and now we come all the way to the SP. These are just subtle differences between the SI, XI versus the SP. You can see in the SI, XI, the arms come from an angle, but the SP is a single port from which the arms will come out. In terms of retractors that we use, we like to use the Crowe-Davis or the FKWO. This is great for tongue base or supraglottic tumors. So the indications, T1, T2, and some T3 tumors of the oropharynx, unknown primary HPV positive and HPV negative, parapharyngeal space masses, select supraglottic T1 to T3 tumors, and sleep apnea surgery. Contraindications to TORS vary by institution, but certain things are true. Trismus, obstructive dentition, restricted neck extension, and inability to stop anticoagulation. These are big considerations. Certain disease factors like base of tongue tumors crossing midline, extension to deep musculature, tongue musculature, and nodal burden. What about the retropharyngeal carotid? Well, that is a relative contraindication. We'll discuss that more in a little bit. So this is just an example of a tumor that we saw there on the right tonsil. This is thus the steps that we use. Again, we make a space and we get into the parapharyngeal space right here. And you can see the equivalent of that in this diagram. And then we come across inferiorly, and we often find the lingual artery. In this particular case, I got into it inadvertently. And then we make the superior cut in the palate, and then we are onto the posterior pharyngeal wall. We use the ligature here for these lateral cuts of the stylopharyngeus and styloglossus. And again, you can see that complex right here. We usually again use a ligature for these last cuts in order to be able to and you can see the lingual artery here again. And we are able to remove the entire tumor in one piece. And that's it. So what about redefining close margins? Well, what we have found is that there's no consensus on what a close margin is. In a lot of people consider 5 millimeters to be a close margin. Here at Penn, we use 2 millimeters as the cutoff. Again, this is because there's no great, we found that HPV positive tumors just react much better than HPV negative tumors. In terms of reconstruction, there's a variety of reconstructions. You can borrow local, like a buccal fat, sometimes palatal island, uvula flap. And what we have done here is the use of free flaps. For us, the indication is more than a third of the hard palate carotid exposure. So for instance, a retropharyngeal carotid, base of tongue resection greater than 50%, and prior radiation. And these are all the swallowing outcomes, and we found that these patients do incredibly well. All of them are decannulated and are doing well postoperatively eating. This is a picture of the free flap that was placed that we took from the arm. And in terms of complications of robotic surgery, the biggest complication is bleeding. And that's why we talk about ligation of the artery, the branches of the external carotid artery. Postoperatively, we have them on steroids, pain control, antibiotics. We have them be evaluated by our speech and language pathologist. Some people have a tracheotomy, which is a very small percentage. 80% of our patients go home without a feeding tube in their nose. 20% go home with it, and then it's removed a week later. This is a picture of a patient with a free flap 6 weeks after surgery. You can see right here, this is where the flap is, and the whole idea is we want to obliterate that space. And they're doing well there. And this is one 6 months afterwards. You can see this is the free flap, and it looks very healthy. So what about how do these patients do? Well, there's a systematic review and meta-analysis looking at transoral robotic surgery and IMRT. They found that there were 17 prospective studies, 27 retrospective studies, of which 3 were randomized control trials. Only 1 randomized control trial that directly compared the 2 strategies. This included almost 5,500 patients. Majority were in the IMRT group. And they found that IMRT of patients majority were treated with concurrent chemotherapy. TORS, majority were treated with adjuvant therapy. Overall survival was 87% for these patients. IMRT was about 84% compared to TORS, that was 91%. Disease-free survival was 90% in TORS, IMRT was about 80%. Functionally, again, this wasn't studied very well. It was only seen in about 28% of these patients, 28% of studies. IMRT feeding tube dependence was 4% versus 1%. Again, not significantly different. In terms of trach tube dependence, it was 1% versus 0.2%. Again, not statistically significant. So overall, patients with transoral robotic surgery have done very well. How about functionally? There's several systematic reviews out there in the literature that have gone through this, and these patients do very well. Future directions, we want to study about circulating HPV DNA. This is something that we have started to look at, where we realize that this is not a blood test that can be used to detect cancer. However, we think we can use this as a marker to understand how, if the disease can be tracked. So patients, if they have a high HPV DNA level before the operation, and then we take it after the operation, and if it drops to 0, we think we can use this HPV DNA to track the progress. There's several immunotherapy trials like nivolumab, which is a new PD-L1 inhibitor, and then something called tumor glow, which is injecting the patient with a certain certain dye that basically gains access to the tumor and allows us to just cut what is necessary. So in conclusion, HPV positive cancer is a different disease modality. Outcomes are great. Make sure that all cancers get reflexive HPV testing, because P16 testing is different than PCR testing. We want to counsel patients on their options. We want to minimize toxicities. Want to lean on your multidisciplinary clinic to help formulate a treatment plan. Lastly, it's always good to participate in clinical trials. Thank you all very much for your attention. This is my email and contact information. It's +1, that's for the US. And if you have any questions, I look forward to hearing from you. Thank you.